Good afternoon, everyone, and thanks for joining us today. I'm Amy Conger, the Managing Director of the Center for Global Health Equity, and I'm pleased to welcome all of you to our final seminar of the fall 2021 semester. Are we asking the right questions? Leveraging ethnography for global health research. At the center, our seminar series is organized under a broad theme of framing our commitment to global health equity. And these sessions provide space for colleagues from diverse backgrounds and disciplines to come together and explore critical issues in our field. So just for context, we opened the series by examining the thorny question of what do we actually mean by equity in global health? And colleagues from Ethiopia, Rwanda, and across the shared their perspectives and ideas on how to conceptualize this work. And in the next seminar, we turn to wicked problems in vaccine equity, featuring an expert from India and several researchers who are helping us shape a broader movement in global vaccine equity research and impact. And you're welcome to view our past seminars, which you can find on our center website. But today, we are delighted to continue these multidisciplinary international conversations, this time looking at our work through the lens of ethnographic inquiry. We welcome a special guest expert from the National Institute of Public Health in Mexico, along with colleagues from our anthropology department in the College of Literature, Science in the Arts. And Professor Cheryl Moyer from our medical school is moderating today's seminar. So I will turn it over to you, Professor Moyer, to kick off the conversation.
Great. Well, thank you so much. It is such a joy to be here. And one of the things I love about being at Michigan is the opportunity to have conversations like this and to be able to learn from some of our colleagues who we often don't have a chance to ask these kinds of questions of. So we're going to start with some self-introductions. So my name is Cheryl Moyer. I am an associate professor in the departments of Learning Health Sciences and OBGYN in the medical school. My background is public health, both health behavior, health education, and health management and policy. And most of my research is in sub-Saharan Africa, focused on maternal and newborn health outcomes. Specifically, I love partnering with clinicians who are focused on the clinical outcomes, whereas I'm more focused on the social and cultural factors that impact those outcomes. So as part of that, I've done a lot of qualitative work, but I confess I kind of quake when the word ethnography comes up because it just feels like something rather terrifying. So I'm especially excited to have a chance to listen to our colleagues and have a better understanding of exactly what we are talking about when we talk about ethnography. So I would love to offer up some other self-introductions. So Mara, if you don't mind terribly introducing yourself, that would be fabulous.
Absolutely. Hello, everybody. Good morning in Mexico. So my name, officially speaking, is Martha Telles Rojo. I go by Mara, and I really thank the opportunity of having this fun discussion with you. My background, and I have to confess, is in math. So in my college was in math, my master's in statistics, and then I did a PhD in epidemiology, basically environmental epidemiology. And my main focus of research is on effects of metal exposures on a very different and very wide spectrum of outcomes, starting for cognitive, but not only cognition, also growth and long-term effects of metal exposures. As you can see, my background is in numerical epidemiology. And I think that the fun of being today with you is that we can talk about how my perspective of research has changed about these years of working with Lisa Roberts. Thank you.
Thank you so much. And it is so wonderful to have you here all the way from Cuernavaca. So
thank you.
Scott, if you don't mind terribly introducing yourself, that would be great.
Great. I'm Scott Stonington. I have a combined degree, MD, PhD degree in medicine and anthropology. I'm a practicing physician. I do hospital medicine at the VA here in Ann Arbor, and I also do primary care in a clinic that used to be a free clinic for undocumented folks and is now mostly Affordable Care Act patients. And I'm also an anthropologist, and I do ethnography, and I love ethnography, and I really would like, one of my goals in life is to have Cheryl Moyer feel less afraid of ethnography so that we can convert her to doing it all the time. My work is in Thailand on palliative care and pain management. And then also, because I'm a physician and I practice in the US, I've done a lot of thinking about clinical spaces in the US from an ethnographic perspective, as well as having to do it myself.
Fabulous. And finishing out, Liz, how about you?
Hi, everyone. First of all, I want to say thanks to the Center for Global Health Equity and Amy and Cheryl for making this event happen, because I too am really hoping to diffuse anxieties about ethnography, but also to share a lot more about what it is and to give people ideas about how they might start incorporating it in their global health research. So I'm a medical anthropologist, and my work primarily over the years has been in Latin America on things like reproductive health, infertility medicine. And then starting in 2012, I started working on collaboration with folks in environmental health here at the University of Michigan and in Mexico, including Mara, who's one of my closest collaborators. What I'm trying to do is do this work to do the work itself, but to also think methodologically about ways that we can bring public health, global health together with ethnographic methods in ways that I think are incredibly powerful.
Which is a wonderful segue into our first question, which is directed at you, Liz. I'd love for you to give us a bit of an overview. What does ethnography mean to you?
Okay, well, thank you so much. And what I'm going to do to help explain ethnography is share with you folks a few slides, because often pictures and a few bullet points can really do a lot of work. So like I said, I'm a medical anthropologist, and I've been collaborating with the environmental health scientists and more recently environmental engineers since about 2012, 2013. And I want to take you through what ethnography is and why I think it could be such a powerful tool for making global health knowledge and for producing more global health equity. So I collaborate with these environmental health scientists who are primarily part of a long-term project called ELEMENT. And ELEMENT stands for Early Life Exposures in Mexico to Environmental Health Toxicants. The PI is Karen Peterson, who's the chair of nutrition here at the University of Michigan. And since 1994, ELEMENT has followed several hundred working class mother-child pairs in Mexico City. And it started off as a longitudinal, well, it started off as a study to look at development over the life course in terms of lead exposure, and then expanded to other kinds of exposures and looking at other kinds of health outcomes. And so in 2012, I approached Karen actually and asked her if it would be possible to imagine some kind of collaboration. And at that time, I kind of had vague ideas about what I wanted that to look like, but no real firm ideas. And Karen was open enough to allow this to happen. And so I basically started getting to know the ELEMENT project, but then immediately started to try to figure out ways that I could work more closely with participants in the ELEMENT project to do what we call ethnography. And I'm going to take you through that a bit more, but I just want to say that in some ways, my idea from the beginning was to figure out how ethnography could be a way to design collaborative studies within ELEMENT to focus on health and inequalities in new and creative ways. So, and Mara became one of my closest collaborators in this, and she'll tell you a little bit more about what that process was like for her on this end. So what that meant in a really rough way is that I spent a year working very closely with ELEMENT participants living in neighborhoods where they lived, getting to know everything that I could about their everyday life. It meant shopping, going to church with people, taking kids to school, preparing meals together, going to street parties, eating, talking, going to Zumba classes, watching people people pay bills, and just talking constantly. And with that work, patterns begin to emerge about what's important in everyday life for these families in these working class neighborhoods that you can't really see otherwise. So, oh dear. I'm trying to figure out, oh, there we go. Sorry, it's just slow. So a way to think about ethnography is that it's long-term intensive, usually intensive, observational research with small numbers of people, which indicates larger patterns. One of the key facets of ethnography is that you don't limit the scope of inquiry in advance. You don't decide, in advance what the right questions are. And that connects to this aspect of ethnography that I think Scott and I both talk about as epistemic humility, where again, you just really don't think that you know what the right questions are or what is important to the people that you're spending time with and observing. These are all images from the ethnographic work I've been doing over the years in Mexico City. And there's an image in the top right of me taking field notes while a woman that I know and work with really closely is cooking. So when I talk about ethnography to folks in public health or global health, they often say, oh, that's mixed methods. And they're completely right. It's a mixed method. It's bringing qualitative and quantitative, or it could bring qualitative and quantitative data together. But a key difference between ethnographic work and most other kinds of mixed methods is that the qualitative approaches in those mixed methods still decide in advance what the questions are. So if you're going to do open-ended interviews or focus groups, the interviewer or the focus group leader is going to ask about a specific set of questions. And I'm all for focus groups and open-ended interviews. I just think that with ethnography, those should be the second step instead of the first step. So because what if those aren't the relevant topics or questions for the group under study in terms of what matters to them or what might be shaping their health? So I'm going to now take you through a story that is kind of simple, but I think helps illuminate a lot of what we're getting at about how ethnography could be a very powerful contributor to making equitable global health knowledge. So you just need a little bit of background to kind of understand this story. So in 2013, Mexico was declared the most obese industrial nation in the world. Folks in public health in Mexico were quite aware of the high incidence of obesity and diabetes and cardiovascular disease in Mexico. But with that announcement, there was even more urgency. And this poster at the top, which says, would you give your children 12 tablespoons of sugar a day? If not, why are you giving them soda? Is really indicative of the kind of billboards that are all around Mexico City in from 2010 on, but they were really prevalent in 2013, 14 when I started doing work there. And they're just everywhere, blanketing the cityscape. And then policies got put in place in Mexico City that forbid parents to send soda with children in their school lunch boxes. And maybe we can talk more later about what the idea behind these policies are and research about the effects of those kinds of policies. But so I was doing intensive ethnographic work at that time with Element participants, and that meant spending time in their homes. And one morning I was spending time in Alma's home with her and her two children, her two daughters, they're pictured there, who are both Element participants. And as Alma was getting their lunches together, she showed me how she had a little water bottle and she poured the water out and then filled it with clear soda, like a 7-Up kind of soda, and started laughing and telling me there's this rule in place, but of course I need to send soda with my girls to school. And so this is how I do it. We trick the teachers. So that was very interesting to see. And it came out of the fact that I was just kind of there, just hanging out and watching everyday life. So a few things I want to point out about that is that over time, through this long-term observational research, ethnography allowed me to register that Alma stuck soda in her daughter's lunchbox, why that made sense to her. I also came to know and knew then that she cares about her daughter's health just as much as any of you care about your children's health or your family members' health. And telling Alma not to drink soda or give it to her kids because it's unhealthy might not be the most useful intervention. So observations like this and a multitude of other very open-ended observations allowed me to gather a sense of just why water is so distrusted in working class neighborhoods in Mexico City and why soda is everywhere and it is trusted. So again, hopefully we can talk more about this if you need enlightenment or more discussion in the Q&A, but I came to realize in these neighborhoods, water is unreliable, it's unhealthy, it could have bacteria in it, it costs money, it doesn't involve any kind of pleasure, so it's antisocial, and water tends to be needed for other things like bathing, cooking, and cleaning. On the other hand, soda is completely reliable. It's healthy, doesn't have bacteria. It's going to always pretty much be the same. It's cheap and subsidized in all kinds of ways by both governments and the way corporations do their work. And it's incredibly social and pleasurable, and you really only need it for drinking and sharing. So just then want to have a comment here on the methodological contrast between standard survey methods that we use in public health and ethnography. So standard survey questions that you might ask on an FFQ, a food frequency questionnaire, might say something along the lines of, how much soda did you drink last week? So from watching these interactions over time and being in people's homes and working class neighborhoods, I knew that these kinds of questions actually do a lot to exacerbate class division, because people who are being surveyed know that the interviewers probably think it's unhealthy to drink soda. And qualitative survey data can produce numerical data, but it very likely might be unreliable data. Ethnography, on the other hand, is all about spending time observing daily life, where you could notice something like soda is everywhere, that people are hiding soda in water bottles, that soda is important for connection with others, and that water is not reliable. Ethnography in and of itself does not produce numerical data, but it can be an enormously powerful tool for making knowledge to generate hypotheses through quantitative data. So these kinds of observations went into making or bringing about one of the biggest endeavors I'm involved with now, which is also with Maura and several other people from Element, along with environmental engineers. Since 2019, we've been engaged in this project called Neighborhood Environments as Socio-Techno-Biosystems, Water Quality, Public Trust, and Health in Mexico City. It's funded by the NSF. And it's kind of based on these kinds of simple observations about why people don't drink water. We want to get a better quantitative sense of what that's all about, but we're combining ethnography, engineering, and environmental health methods to do it. And we're visiting 60 Element households over 3 visits to collect this kind of data. But a lot of it is coming out of this seedbed of ethnographic knowledge. Last slide here then. So what, hope you have a little better sense of what ethnography is at this point. And I just want to say that I think a very important point is that researchers in global public health tend to be from resource stable and resource rich worlds, and thus don't really know that much about the realities of the people's the lives of the people that they study. Ethnographers have been brought in for quite a long time in public health research, but it's often just in a consulting kind of position where they're asked to kind of come in and tell things after the questions have been formulated, or to consult on data after it's gathered. And what we're talking about here is integrated and iterative ethnographic collaboration. So better hypotheses can come from starting with an open-ended ethnographic phase, and better interpretations of the data can come from involving ethnographers through the whole research process. And then here is a set of images of all these collaborative research teams that I've had the privilege to be a part of in the last few years. Thanks.
That was fantastic. Thank you so much, Liz. So one of my next questions is for Maura, actually. And I think, Liz, if you don't mind stopping sharing, we can go back to the gallery view. Maura, I'd love to hear your perspective on what it has been like as an epidemiologist with quantitative training to be partnering with ethnographers. Can you speak a little bit to that?
Absolutely, Cheryl. First of all, it has been a lot of fun, which I think is key to do good work. So I would like to talk a little bit about challenges. So I want to come back to the idea when that Liz just mentioned when she started working with Element. I am the Mexico PI of the cohort for many, many years. And I knew about this researcher, anthropologist from UMich that want to do some work in Mexico. And we had this wonderful lunch together when we met. And the first thing that I realized is that, whoa, we had a wonderful conversation. Talking with Liz is joy. But at some point we start talking about work. And what do you want to do? Oh, I want to live with 6 families in neighborhoods. And my first question was, and what is your hypothesis? What you're looking for? Nothing. It's an open-ended, no hypothesis-driven research. And it was a big challenge to me because in my world, everything is hypothesis-driven. It was clear that there was a challenge of methodological challenge. And then we said, well, okay, I can understand that. Hard for me, but I can do my effort. But what else? Well, how are you gonna do the methods? I mean, what is the methodology for doing this? I will hang out with them. I said, hang out? What is that? I will leave, I will go to church, I will go to school. And to me was a big shock. Now, how can you do this as at that time I said as research? And how many families are you thinking on studying? Our Element cohort study started with 1,200, and now we are evaluating about 800 families. Six. So the big challenge was communication, language, research methods. She started working in the project, and one day she said, can I have the information about the 6 families? Yes, of course. What do you need? Everything. You're talking about 20 years of information. I mean, it's a huge server at UMich. Everything. It was clear that when we were talking about variables, fixed variables in a matrix, in a database, rows and columns, she was like a world wide open. The challenges were huge, but it was clear that it was appealing, sounds interesting, and we started working. Along the years, I have learned many things, and I don't want to expand on it more than the time that I have, but I was trying to summarize the experience of working with Liz. And I read this story. It's like if you lost your car keys in a dark room and you turn on the lamp. And while the numerical epidemiological methods that I learned would advise me to look in the spot of light that the lamp would put light on it, I don't know how to say it, ethnography brings options from the dark part. Look the car keys all over the room, not only in the light. It's a different way of understanding reality, and it's not an easy challenge to work with, but super interesting.
I love that analogy. That is beautiful. If I can just follow up on what you've said, one of the questions is sort of how you've experienced the interface between epidemiology, public health, and ethnography. And before this call, we talked about your experience with sleep. And I was hoping you might be able to relay a little bit about that.
Yes, absolutely. In the cohort, in Element, we have studied many different outcomes, many different exposures. And in the last few years, we have been studying sleep. Sleep is a big deal these days. After spending my sabbatical in UMich, I understood something. The patterns of sleep are not the same. In Ann Arbor, everybody goes very early in the night. And we used to wake up later. So these kind of things, but it was interesting that our approach was the traditional approach of sleep. How many hours do you sleep? Even you using wearable devices, the patterns of sleep, in the interruptions of sleep. That's the traditional way of studying sleep. And I am not the leader of the sleep component in Element. That's Erika Jansen, and she does a beautiful work. And one day we were talking about this with Liz, and we realized something that it's not specific for the sleep research. It's in our approach, the traditional approach, we have assumptions. We rely on assumptions. We have an approach of standardization. That's the way that we use to analyze sleep. When we talk with Liz, we realized that we were thinking that people sleep in one bed, whereas maybe two people couldn't sleep in one bed. We understood that at least in my mind, we sleep in one bedroom with the lights off, trying to have no noise. But the reality of the participants is completely different. So when I hear at least talking about the way that people goes to sleep, what I thought was that our traditional approach was to start the sleep research was where when you go to bed and you put your face in the pillow, but ignoring all the environment that surrounds this moment. And that environment is so important to understand what we use to work with. So to me, was like bringing a component that maybe could help us to understand better the whys. Why is happening this? And we were just simply reliable on assumptions that we were not aware of.
Thank you. That is super helpful. So Scott, not to leave you off of the panel here, question for you. We've talked a lot about ethnography as ways of uncovering what's in the darkness. What does that have anything to do with equity? How does equity fit into this discussion?
Yeah, that's a good question. And I think a very short answer that then I'll give a longer story to support is that I think for me at the heart of this center actually for global health equity is that in the idea of equity is hidden an assumption that equity requires efficacy and that we have to do things well in order to do them equitably. And in order to do things well, we have to do them accurately, right? We have to pay attention to the real world because that's where stuff actually is occurring. So at the rawest sense, global health equity is an incentive for us to not just do things in ways that are easily publishable, that are easily packaged and recognizable to others, but in ways that actually get measurable good outcomes in various parts of the world. And that those outcomes themselves may need to, what matters most in terms of outcomes may need to vary in certain ways from place to place. And I know we've been talking about research, but I think maybe I'll give an example of an intervention just because it's sort of easier to see the stakes of equity when it comes to an intervention. And there's a story of a case that I wasn't involved in, but that a few anthropologist friends were quite involved in. And it was in the early phase of the rollout of antiretrovirals for HIV in Southeast Africa, in Mozambique. And it was a time when it was controversial whether treatment for HIV could even be part of the solution globally. And many people were making cost effectiveness arguments that we just needed to do prevention in the developing world. So it was a very equity-oriented time and a very equity-oriented move. And a coalition of organizations put together a project to treat and scale up a large number of people in Mozambique with antiretrovirals, that the first highly active antiretrovirals had come out. And they were equipped, there was some urgency to this because of the political need to show that this was doable. And they were equipped with a set of experiences that they had developed doing the same kinds of scale ups and trials, mostly in the United States and in Europe. And so they landed on the ground and they're like, we got this, we know how to do it. And it was actually wildly impressive, beautiful, kind of world-changing intervention, or at least field-changing in global health. They developed this set of clinics in each of the district areas. They had mobile vans that drove around to people's villages and did directly observed therapy, which was the standard of care in HIV therapy. And it was super well distributed. It was very impressive. And at first it was wildly successful until they started noticing that people were not showing up to pick up their antiretrovirals anymore, and they were increasingly having to chase people down in the villages. And when they asked people about this, folks said, your medications make us hungry and we're already starving. And this was like a, oh my God, terrifying moment, because, you know, with antiretrovirals, if people aren't taking their meds, you could create a resistant strain and you could do more harm than you started out with. And so this was a huge panic, scramble, figure out what to do. And they started looking back in the literature and seeing that in the trials in the US, there was a signal, there was a quantitative signal that people reported that the heart regimens made them more hungry. But in a resource-rich, overnourished context, that was like not on anybody's radar. It didn't make it in any of the publications about the side effects of the medication. It was like a non-thing. But in a place where there's 50% severe malnutrition rates and everybody's dying of starvation as much as they are of HIV, it was suddenly, people would say it was worse than torture and they would rather die than experience that extra hunger on top of their hunger. So they freaked out and figured out what are we going to do in a programmatic way, and they started giving people bags of food with their antiretrovirals. And that seemed like a great solution to the problem as it was showing up to them. But people had these very elaborate moral economies of debt in their families where it would have been absolutely preposterous to show up with a bag of food and not feed everybody else in your family. And so people started sharing the food in their families, and it was still not enough to keep people out of this severe hunger. And then they started seeing a signal that people weren't recovering from opportunistic infections very well because they didn't have the calories they needed to mount the immune reconstitution that they should be having as the virus cleared from their system. And so they put together a program to start giving people enough food to feed the size of an average nuclear family. And when they did this, they started hearing from people in the community who were coming to get their meds that there were rumors circulating that if you intentionally contracted HIV, then this organization would come and treat your disease and feed your entire family. So maybe you should try to get HIV. So, you know, this is, I'm very quickly telling what is a very plot-filled and long story. And the thing I want to not put this down as like an example of a failure. In fact, when I teach my global health classes, I teach global health, I teach this as like a pivotal, very important and brilliant moment in the turn of events in the history of global health. And it was wildly impressive. They like ramped up and got hundreds of thousands of people on antiretrovirals at a time when critics said it couldn't be done. But the people who were involved in the study talk about it as they were constantly in a reactive mode. Like they had this model that was supposed to apply everywhere. And in global health and in public health, we use these terms like, is this transferable? Can you scale this up? How do you scale up this intervention? We've got all these words that are about building bigger and bigger bureaucratic solutions out of test cases and pilots and stuff. But that intervention landed into a world that people were part of that was different from the world where that had been designed. And my theory and the folks that I talked to who were involved in that intervention, they say, you know, it wouldn't have taken that much to have done a little bit of work around the question of how does this context differ from the context where we designed what we're doing. It wouldn't have taken needing an anthropologist to live in the community for 3 years and do it. It wouldn't have taken too many local collaborations or too many people who do this kind of work. So some combination of partnerships and this kind of ethnography we're talking about would have given us a treasure trove of answers to the question, how is this all going to land differently in this place than the place where we designed it or than we expect it's going to? So how is that about equity? It's about equity because if you want your interventions to work and not have extra people die and not get resistant strains of HIV and have people intentionally contract infections, you need this kind of framework for how to weave it in so that you're not always playing catch up. And in global health, we use these terms like unintended consequences or perverse incentives or logistical complications. Those are all cop-out ways of saying we didn't think to pay attention before we got started. So my feeling just in the raw world of global health interventions and delivery and raw outcome-oriented stuff is I think we have to step back from that passive voice and figure out how to involve this stuff in how we think about things before we get started. Cheryl, I don't know if is that helpful?
That is extremely helpful. And, I have heard you talk about that story before, and it has stayed with me. I think about that so often, I can't even tell you. So I hope that we can all remember that and learn from it as we think about going forward in whatever global health world we're in. So Liz, I'd like to circle back. Mara talked about some of the challenges of being a quantitative-minded epidemiologist and encountering an ethnographer. I'd love to ask that question of you on the other side. What are some of the challenges of being an ethnographer working on a quantitative team?
Thank you. I mean, first of all, I'd love to thank you for these questions, but also it's just great to hear Mara tell her story of what it's like, and then to hear the way that Scott thinks about this in terms of global health equity. So there's a lot of challenges to doing this kind of research. And I think, you can kind of put them in different kinds of buckets. And some of the challenges are, I think, stuff that probably most people could kind of understand about, when we talk about disciplinary silos, it's just so hard to work across because the language is different in the way that Mara was talking about. And I think for me, a lot of the language, I don't have a quantitative background, and I'm also used to using a lot of words when I talk to people and not having kind of like, and here's the answer. And so I've really had to work on trying to figure out what are the things that are important to my collaborators? How can I talk to them in a way that is meaningful to them? And I've made plenty of mistakes along the way. And I think when I first came back from doing the research, I thought I was going to show up at the element meetings and say, like, I know all this stuff now. Don't you want to hear it? Just ask me anything. And it's just completely not the way that public health or environmental health research works. And I had to learn that. And I had to learn, like, no, I need to demonstrate the ways that I can help them actually ask better questions. And I would have to say Mara and some of the other researchers have been incredibly generous with their time to help me do that by working together to show kind of proof of concept things. Like this sleep study, I think in some way has been a proof of concept because we were able to ask different questions on the surveys that ended up giving really interesting results that no one predicted. And we've done other smaller scale things like that, but it really was about patience and goodwill. And then I think there's other challenges that aren't really solvable yet at this level of only at an interpersonal level in any kind of way of like having the goodwill or having the patience or finding it really fun or enlivening to work with each other. It's about all of what we in anthropology would call structural constraints to making richly contextual knowledge together. And that's all about the way that NIH does funding, about the models in most global health, public health research that is focused on individuals and studying and having algorithms and mathematical models in place that's only about looking about the relationship of individual chemicals on individual bodies and expanding that outward is difficult just because of the way the models work and because that is what is funded. And we have tried to get substantial funding so that this approach has legs, and haven't been able to really do that yet because, you know, the NIH just isn't in the business of doing that, except actually in HIV and drug use prevention work. So they're at every level. And then there's also things within our world, LSA world, or letters and sciences world, where my job isn't really structured to do collaborative research at all. And so I have had to learn. I've been really naive about how that works in many ways and made mistakes, but also, you know, the way our time is divided up and who we answer to and how we train students and how we write collaboratively, all of that is, or we don't write collaboratively usually in anthropology. All of that are things that become stumbling blocks and get in the way. And one other thing I would say, it's just that's much more concrete. I think one thing, now I'm kind of a PI on some of these things. And one thing that I think continues to be very strange and a stumbling block for the public health researchers is that for me to continue to be a good anthropologist, I have to be there. We're experimenting with ways that I can supervise ethnographers, but so much of this rests on my capacity to keep going back to these communities and being there. And that doesn't really fit into funding models or the temporality of how global health works and publication cycles. And so there's just mismatches at every single point.
I absolutely agree on so many levels, but that's a separate story. So I want to back up a second and speak to, or ask specifically, I'm going to ask Scott to speak to kind of the range of ethnography. Like when I think of ethnography, I think of going and living in a community for 3 years and, you know, having no preconceived idea. And then somehow 5 years later, writing a dissertation out of it is kind of like how I envision ethnography. Whereas I'm sure that there are some less intensive styles or methods for ethnography, which gets to one of the questions in the chat. Heather asks, in ethnography, how do you determine how long to spend time with families or study participants, and how do you select them so they're representative of a larger sample? So Scott, can you tackle those two things, like the range of what ethnography means, and then how do you figure out who to talk to?
Yeah, I'm so glad you asked, because I really don't want to leave the impression that you either have to go live for years in places or that the only way to do it is to collaborate with people who are doing that depth of research, because I do think that there's a range of types of inquiry and style and sort of magnitudes of inquiry. And so I would bring the focus a little bit back to something that Liz said in her presentation about the purpose of data gathering, that I think there's a little bit of the spirit of the law that can be taken away from that then opens up the range of how intensive it needs to be in a way that I think can be super useful to public health folks. So the way I talk about ethnography is I usually teach it as a kind of iterative hypothesis testing. Whereas in, you know, the lab sciences and in public health, we often think of, you know, there is a hypothesis and then you design an instrument and then you get an answer. And there's just one process, right? Well, ethnography is like it's like an infinite loop or a really fast loop of lots of those tests happening. So what Liz was presenting as like you go in without a hypothesis. There are ways of doing it where what you go in with is not so much just having no hypothesis, because maybe you don't have time for that level of depth of work or breadth, length of work. But instead, what you're doing is any form of inquiry where what you're saying is my hypothesis the right one? Where anytime you're saying, okay, the work I'm doing here is to help me generate questions that I can't think of on my own by reading the literature or sitting and being smart in my office in Ann Arbor. So anything that is question generating in a way has to be ethnographic, because the only place to go to generate that information is to the lives and worlds of the people that you will be working with, right? So The only reason I go into that kind of sort of theory detail is because I think it can give you a sense of what the process is like, which then you can back up into how long do you need to be there and this whole idea of representativeness. So when I went to go, so my fieldwork was on end-of-life care in Thailand, and it was about stuff that here we would call bioethical. How do people make decisions? What are the right and wrong things to do around decisions? And that was all I had in my toolkit going to Thailand, but I knew it was going to be wrong. I knew that my whole model, like the only reason I was going to Thailand is because I knew my whole model was going to be wrong. So I go and into the field. It's not like I don't have a hypothesis. My first hypothesis is, does Western bioethics fit what I'm looking at? And I know in the back of my mind, it's not going to, right? So then I have an experience and it throws something in my face that is like totally different from what I was expecting. And I go back and I rewrite my whole model to include what I'm looking at. And I do that with every experience I have. Every interview is a different interview than the interview I did before, because I'm no longer curious about the same things. I'm curious about stuff that came up in the last interview. I know those of you who do like mixed methods where you want your interviews to be quantifiable so you can publish them in a table are starting to develop hives right now. So, but what this does is, you know, in my fieldwork, the beginning of fieldwork was very disorienting. And every experience I had was like, oh my gosh, in my face, I am so wrong about what matters. I'm wrong about what questions to ask. I'm wrong about, but then by the end of fieldwork, I'm no longer having that experience. In fact, my experience is sort of that feeling you get when you do your survey and you are analyzing your data. It's like I'm moved into a mode of confirming my model rather than turning my model into total turmoil. And at the end of my fieldwork, I'm going to people and I'm like, hey, here's my model of how all this works. And their response is, wow, we've never formulated it that formally, but you totally get it, right? So there's a kind of iterative process that's not just totally free for all open. You just go absorb for forever and get wiser and wiser, right? That helps you decide a little bit about how long. So how open, how big your aperture is at the beginning determines a little bit about how long you need to be there before you start to stabilize, right? The second point is it also helps you make sense of this idea of like a stratified or representative sample, because in in the basic sciences, we reduce systems out and we experiment on them, and we have this idea that you can experiment on the world, or that you're trying to like represent the world in some way. But part of what we're doing in ethnographic inquiry is we're trying to come up with a model of how the whole thing is put together. And so people also often ask about outliers, like how do you know you're not looking at something that's really weird and doesn't actually represent where you are? Well, outliers, if you're trying to generate hypotheses, outliers are some of the most useful thing you can find, because all you get to ask people, you're there, you're part of it. So you get to say, why is this weird? Why is it an outlier? How is this defined as different from the norm? And suddenly people are telling you all about how things are actually put together at the center of it. So the idea of stratified representative samples kind of goes out the window. And the idea of needing to gather a certain N, like a certain number, a certain quantity, also goes out the window. And in that kind of hypothesis generating or question generating work, your focus is shifted to, I'm looking for new ways of looking at the problem, and I know I'm done when when it has stabilized and I'm no longer so confused all the time. Is that helpful, Cheryl?
Absolutely. And I think, Mara, what are your thoughts on what Scott just said?
First of all, I think that the point about the length of the time in the field is key to make this happen. And I want to go back to the experience that we have had with Lisa's work. And what I described was when she spent a year living with the element participants, 6 months with 3 families and 6 months with the other 3. But that was a completely ethnographic work. And then our next step, how can we do something together, combining methods? It was interesting to me that the third party was a biostatistician that we started working with, Brisa Sanchez. And the next step was this project that Lisa talked about, NESMEX, that instead of studying 6 families, we are now studying 60. So it's 10 times higher. And there are 3 interviews of about 3 hours each. So we really try to combine these methods in a single evaluation with a lot of challenges, because we try to make this discussion reality in a research project. And now the next step of our work, and I shouldn't say our work, it's more Lisa's work, is we are conducting, even in the COVID context, interviews by phone with trying to study sleep and menopause in a small sample of element women. So I think that something that we learned is that when we try to take this conversation into reality, moving from a very quantitative world as element is, and trying to combine Lisa, we need to move from our starting points. If we were still thinking on 6 months, Lisa would still be thinking on only ethnography, but we both move, and we are trying to do something that we call mixed methods, and we're in the process, but it became feasible. That was my comment.
Yeah, Liz.
Hi there. It's just so great to have Mara and Scott both talking at the same time, 2 of my favorite people to think with about this. I wanted to add a little bit more to this by saying that after Mara and I had been working for a few years, she came up with this wonderful word for what I think, or for what she saw me doing, which is that ethnography was providing a semillero, a seed bed in which to go do other things, or to ask more questions that can become increasingly mixed methods over time. And it's interesting because I think in some ways the vast amount of data Element has gathered is also gets called a biobank all the time, but it's also a seed bed in all these ways. And I just wanted to use that as a way to address what Scott was getting at about, you wouldn't even take that much time to do this. And I think there's all kinds of ways that people could be very creative and thoughtful about incorporating ethnography. One of them, and I mean, I think you dismissed it a little bit, Scott, but you're going to a part of the world in Mozambique where there's tons of anthropologists that have been working for a really, really long time and could probably tell you a massive amount about what it might be like to hand out antiretrovirals in households that don't have access to the amount of nutrition that you expect, or you might not even know what the issue is because you're not thinking about malnutrition. You could say, I need someone that either works in rural or urban areas. Their seedbed of knowledge is extraordinary. I'm sure I can guarantee that to you. And so that is one way to get at that kind of seedbed is to incorporate. And in fact, one of the projects that inspired me is here at University of Michigan, ECODES, which Joe Eisenberg started with an anthropologist who hadn't worked in that exact area of Ecuador, but had long experience with diarrheal disease as an anthropologist all over Latin America. And so was able to think what might be the things that we start looking for. The other thing I want to say, and this kind of gets to this question, but it's I think one of the hardest things, getting back to the challenges, but I just want to name it and put it on the table, which is so much of public health and global health is based on the assumptions of kind of a universality of experience. So you can do interventions and you can do research thinking like the way that lead affects these people here is you can just take that knowledge and put it elsewhere and you can scale up the knowledge, not just the study. But so much of what anthropologists and anthropological work does is show like, it's kind of like what about these bodies with this lead or these antiretrovirals? And so assuming that you know anything about how the bodies or the context works, again, sitting being smart in your office in Ann Arbor, is going to be a disservice that is going to potentially create inequity in the long term and potentially in the short term too.
So far, a lot of what I've heard you all talking about is idea generation and thinking about, changing the way we think about which research questions we're coming forward with. Can you speak a little bit to how ethnography is useful, or I guess I should reframe. One question is, isn't ethnography most useful in the formative stages of research? Or how might it look throughout the rest of the research process? And Liz, you're nodding, so you get to go first.
I want to not go first because I talk too much, but I have lots to say. Mara and Scott.
Go, Scott.
So I don't know how I got chosen for this one, but I'm sure we all have lots of opinions about this. So you can probably, our listeners can predict the answer, which is all the way through. It is wildly, wildly helpful all the way through. And I just want to say a quick word about funding. And so we've talked a lot about obstacles, but people who, just from my experience interacting with granting agencies and reviewing grants and thinking a little bit about that world, the folks who figure out how to not just do mixed methods as I'm going to ask questions and then I'm just going to gather a salad bar of data and kind of present it to give a bigger picture, but who really find this engine between the quantitative and the qualitative, between ethnographic, between hypothesis generation and answering questions, who really find that engine, they get wildly well funded. Like I'm thinking of Philippe Bourgois, who put together an NIH grant that the year that he put it together was the highest scored NIH grant of all of them. It was people are like, I was top 2%. This was like the number one. And because it was like generating these unbelievable revolutionary ideas. So good work, like it shifts the field. And some of how you do that is through this kind of hypothesis asking different questions, then answering them in different ways, using the quantitative data to show you qualitative stuff, using the qualitative stuff to generate new, just as an engine. I wanted to get that out there. Another thing is that, people say, well, I can't write a grant to do pilot work that's ethnographic. So the bootstrap way to do that is to always be incorporating ethnography. When you're there doing your quantitative work, you're doing your qualitative work for the next time, and you're doing ethnographic work about the things that you're doing, so that there's just always kind of a rich, vibrant conversation about what types of data you have, what your categories are, where they're coming from. That would be my, since we're close to time, that was my 2-minute version.
Liz, would you like to follow up?
Yes, so much to say. So the answer about when, like Scott, and that was one of the points on my slides, all the way through, and some examples that I can give you, kind of a small example, but hopefully something to wrap people's heads around, is one of the most generous things Mara did early on was I had all of this data, ethnographic data about the way that this one neighborhood potentially had more toxicity in that neighborhood, and for all kinds of really interesting reasons. But Element had never thought about things on a neighborhood level before. It was all about individual bodies in a cohort. And she worked with me, along with many other people that we had to enroll, to align the data and be able to ask blood lead level data in such a way to understand it by neighborhood, because Element hadn't done that before. They didn't even have a way to say what neighborhood it was in. And just getting the data to do that was a lot of work. And a lot of people with goodwill did that. Once we did it, we found that, lo and behold, there was a statistically important higher lead levels in children in this neighborhood. And that was something that that without ethnography, you couldn't have thought to ask. But then here's also where ethnography needs to come in. And this is a little bit complex and tricky to say, but one thing that the ethnographer can do then is to help you understand that data better. So here's a neighborhood that has, compared to all participants live in, there's higher blood lead levels. But I also know that those higher blood lead levels probably go with the other forms of toxicity in the neighborhood that are keeping out forms of toxins, if you'd want to use a weird term for it, in the neighborhood, like police and police brutality. Like there's all these ways that this neighborhood is creating fortifications to keep people out. So yes, while I don't want people to be exposed to lead, and toxins are painful and, or, you know, not something we want to have happen, there's ways to interpret that data that is potentially different than we just need to create an intervention to lower the lead levels in this neighborhood or overall. So that's kind of an example of the way that you would want ethnographers all the way through. And then there was something else, but maybe it'll come back. Yeah, go ahead, Scott.
I just wanted to say one thing to circle back to something I'd said earlier, which is in the world of health intervention, if you had taken a neighborhood that had higher lead levels and you had done away with some of the barriers that were keeping the police out or gangs out or et cetera, and then you would have had increased violence in that neighborhood, you would always have said afterward, oh, there's always unintended consequences. And oh my goodness, there are unforeseen perverse incentives or logistical challenges that just weren't part of the scope of our study. But pat ourselves on the back, that was all, but of course, it was like well motivated to get lead levels lower in the first place. Now it's very complicated, multifactorial, but I just wanted to name that we have ways of kind of formulating and disowning some of the complexities of our research, that this gets to allow you in a still productive and interesting research oriented way to incorporate into what you're looking at.
Mara, it looked like you were going to say something.
Yes, I want to use the neighborhood blood lead levels example that Lisa just discussed, because I think that to me is a very nice way to comment about ethnography. I am very committed with the with the lead poisoning in Mexico. A lot of research and public health in that regard. And from the quantitative perspective, my goal at the national level was to estimate the prevalence of lead poisoning in the country, maybe at the state level. In the US, there are regular monitor of blood lead levels. In Mexico, there is nothing like that. So if I think as an epidemiologist, I would picture a model, a statistical model with the prevalence maybe as the outcome and another such of variables that help me to understand that prevalence and an error term. And that error term integrates all the variability that you cannot include in your statistical model. And when I hear Lisa discussing this difference in neighborhoods, and I picture myself talking with the health ministry about the national program, I know that the conversation that we have for the national program has a huge error term. That if we would be able to bring this conversation into the table, that error term would be significantly, as the statisticians say, reduced. So it's like, as I said in my first intervention, is understanding reality from a different perspective. Is instead of talking about the standardization, turn on the light on the details that you do not see when you talk about huge assumptions, homogeneity.
That's such a great point. So there, I'd like to turn to the question. There's a question in the Q&A about what are the panelists' thoughts on autoethnography when a researcher is conducting ethnographic research on a topic they live with and are drawing conclusions from their own experiences. I would love to hear your thoughts on that.
Can you repeat the word that they put on what?
It's on autoethnography, when a researcher is conducting ethnographic research on a topic they live with and are drawing conclusions from their own experiences, as opposed to people's experiences.
Thank you.
Do any of you want to handle that? Go ahead, Scott.
I guess I can jump in because I have done a lot of this because as a practicing doctor, I have done a lot of ethnographic thinking and writing about scenes where I'm a doctor in the scene and my decisions are at stakes and I'm making mistakes and it's very, high stakes and personal. And so just for the background and for everybody, there's a long history to this and sort of a recent conversation in the field about how we are involved, when you are the instrument that is doing the measuring, but then you're also embroiled in the scenes that you're part of. What does that do to knowledge making? And I don't want to be a broken record about this, but I'll answer it in that same way about iterative hypothesis testing. So the nice thing about knowing that when we go to the field that we are going to be wrong, but knowing that we need a model to begin with, to start comparing things with, to start showing what it is that we didn't account for in our model, means that there can be quite a diversity in where those models come from. Because then the process of doing the iterative hypothesis testings makes sure, in fact, it is precisely not about where you got the model from. It's about going to the field, to the people you are working with and studying, for them to tell you all the ways in which you're wrong. So now in this will help sort of explain for folks who maybe have run into the current social sciences that draw a lot from the humanities, and you think to yourself like, wait, how are we going to incorporate in our public health modeling somebody who's reading a novel about the topic that they're dealing with? But all of that can be sources of questions that then we go and we try out over and over again with the community that we're studying, precisely for them to tell us that it's wrong. So good autoethnography looks very different from memoir or creative writing or these sort of pure humanities approaches to things, because while you're reading it, you're like, wait a second, this is very much not about this person. This is about this person maybe using some experience of their own to generate a hypothesis, and then they're going out into the world to test it over and over again and look at all the ways the world is telling them that they're wrong about it.
Liz, did you want to add to that?
Yeah, yes, to what Scott just said. And then I think to kind of take the conversation in just a slightly different direction, which I think gets at this question about global health equity and who researchers are. So anthropology has a long history, like every discipline that was developed in Europe and the United States, of being all about creating more inequity through who's doing the research and who's being researched. And more, anthropology is involving researchers that are not about Europeans or Americans going somewhere and learning something about the other. That there's less and less of that happening. I mean, I don't know if Scott and I are like the last of that generation, but more and more of the grad students that we train are coming from places and communities and nations where they're going to do research in that. They're going to get trained, but they're going to go to Indonesia where they're from, or Mexico where they're from, and they're going to do research in a world that they know much more about. And there's a lot of conversations in anthropology, and there has been for a long time, about the different kinds of value of insider and outsider perspectives, and how actually often two researchers, someone who's from outside a community and from inside together, are almost the most powerful team you could have. And I know when I was doing some of this early research, the fact that my research assistant was from working class communities is the thing that made my research so much better. But I could see things she couldn't, and she saw a million things I couldn't. So researchers doing work in their own communities is more and more just standard in anthropology, not just collaboration with public health. And my dream is that actually public health starts doing more of what I have these different names for it, and Mara and I have come up with ethnoepidemiology, bioethnography, where the training is actually built in. Like, my dream would be to be able to train many more people that work with Element in Mexico City to be able to do this kind of research. I know that the staff at the place where Element happens, like, they're actual knowledge about the communities they're working with is like astounding. They don't have the training to articulate it and tell the researchers that are, usually upper, they have more education and more research as whether or not they come from Mexico or the US. But like autoethnography is the future and it's the now in so many ways. And I do think there's ways that being an outsider is very powerful in terms of being able to see things and also the resources you bring. But it's what we need, and we need more dual training as well. I mean, although dual training is its own complex thing.
So I know I'm the moderator. I'm not supposed to interject too much, but I do have a story that I wanted to share that sort of speaks to this insider outsider, and also speaks a little bit to what I think of as the value of ethnography in terms of understanding our world. So I had to give grand rounds a couple years ago at an institution that didn't do much global health. And most of my work is in rural northern Ghana among moms and babies. And I was trying to figure out how to make the work that I had just been talking about remotely relevant here in the United States. How is this relevant? And some of the work I had been talking about included the fact that grandmothers in this one region in northern Ghana where I work have a tendency to take a lot of ownership of newborn care and feel as though it's their responsibility to make sure that the umbilical cord falls off quickly. So they put all kinds of things on the umbilical cord. They might smear it with shea nut butter. They might put alcohol spirits on it. They might put cow dung on the umbilical cord, which is obviously not great in terms of neonatal sepsis. So me learning about this as an American who's not from this location is sort of like, I'm thinking I'm channeling Scott, thinking, well, what purpose does this serve? And how long has this been going on? And why would you, what are you thinking? And how could we think about some alternatives that maybe aren't toxic? I'm kind of thinking about this. And then it dawns on me that if I were in the United States and someone said to me, my mother-in-law puts cow dung on the umbilical cord, immediately I would go into, that's crazy, that's not safe, that's wrong, etc. I would go into that judgment zone. And the parallel in some regards, let's not talk about COVID anti-vax, let's talk about pediatric anti-vax. Those moms are doing what they believe is best for their baby. They are doing what they believe is best for their baby. And so to harangue them with our judgment of why this is so bad and just hammer them with epidemiological information isn't going to make a lot of headway, I don't think. And so if I could adopt that outsider perspective of, so tell me more, how does this serve you? Let's talk about this. I just wonder about how things could be different. So even though like I have not lived in the community for 3 years, those types of observations, I think, may be helpful for some of us who are on the periphery of ethnography to think about how could that be useful in our day-to-day. So we have about 15 minutes left, and I would love to ask one meta-level question for you all to ponder. The title of this webinar was, Are we asking the right questions? And my question for you is, in global health, are we asking the right questions? And what are we missing? And which of you wants to tackle that first? I'll start with Mara, because you've been quiet. Go ahead, Mara.
I would like to answer these questions in two different ways. One is if we are asking the right questions, or if we can identify new questions. And I also would like to bring how this collaboration with Lisa has impacted the cohort, which I think it's important in our daily life in the cohort. As I said with my metaphor of the lamp, I really think that ethnography has provided us a new way to understand reality. So maybe even if we had the right questions, we may have a good question about the what, but ethnography helped us to understand, or has helped us to understand, the whys. So I think that the right question is too broad to me. It could be also, ethnography can be seen as, I don't know if I will use the word social in the right word, and if I don't, please apologize me. I always very concerned about the wording, but it's like talking about mechanisms, but not biological mechanisms, about social mechanisms, bringing that into our research to reduce the error. No, we understand reality differently. That's one thing. And the other thing that I want to say is that one day Lisa may comment in a circumstantial, not in purpose, that the participants of the cohort perceive the cohort as a health provider. And I say, hold on a second, we are not health providers. We have never aimed that. We are evaluating these people. And it was super interesting because I think that for me, as the Mexico PI of the cohort, has drastically changed my perspective of the cohort, of the participants, because that's true. The quality of the health services that they received in Mexico is so differently that I now understand that they perceive us as a health provider. So I think it's that asking the right questions, but beyond that, it has changed the way that I perceive my research.
Liz, would you like to go next?
Yes, that was great that you brought up mechanisms, Mara, because that gives me a way to, I think, answer this question. I'm going to be a little bit bombastic and hyperbolic here, just kind of for the sake of, let's say something big as we head out the door, which is, I'm going to say no. Global health is not asking the right questions. And there's a lot of different ways that I could frame what I mean by that, but I'm going to use what Mara just said about mechanisms. So I would say that the questions tend to be about individual bodies and behaviors and health outcomes in those individual bodies and behaviors. And what any critical medical anthropologist will tell you is that is exactly the right way to not really know very much about health and where it comes from, and what's causing it. And so Mara just did this thing about mechanism, and she kind of talked about, biological mechanisms and social mechanisms. And what I would say we are really interested in these days in critical medical anthropology is to kind of blow up that distinction and to say, deciding in advance something is biological or social is again going to reinforce this sense that, oh, there's a biological outcome and a social outcome, or we can ask questions separately. But just to go back to the soda, if we're focusing on why people drink soda and not water, and we think about their behaviors and their beliefs, and even just ask them questions about that, and we don't do ethnography to notice that the world is saturated with soda and what it does in the context of not trusting water, we're also not noticing that Coca-Cola is subsidized by the Mexican government and the massive deregulation of corporations around the world that makes it that it is easier to get soda into people's bodies than anything else. And if we don't start taking that into account to understand global health inequity, you are absolutely asking the wrong questions.
Oh my God, yes. I feel like I should stand up and clap. Well done. Well done. Scott?
There's not much to add to that, both of those fabulous points. But one thing I'll say is, we get accustomed in academia to sort of intentionally narrowing our gaze and our area of expertise. And it is just supported by the fact that we have jobs and we have to publish things and we have to see patients. Whatever we do, we have to do it. But I think that one of the promises of something like the Center for Global Health Equity, which is my sense of it, is to trying to crack us out of our individual world and into something bigger where we take on the big questions. that we need to recognize that we are in a moment of like really big crisis of public health. We have lots of epidemiological knowledge. We have lots of reductionist tools, and we are just totally failing. We are not vaccinating people. The Gates Foundation, which in the era of, the turn of the 21st century and the global, like the golden age of global health financing, and we're going to solve HIV and tuberculosis and malaria, is now like harried. And there is this like huge anti-Bill Gates rumor universe where people are like angry and upset. I mean, it's just, and all of us in public health are like, wait, but we're smart and we're good and we know things that are facts, and how does that world get us so wrong? How is the world so stubborn in being dumb that we, so I'm making that more extreme because I was teaching a long time ago in medical school. I was teaching fellow medical students about how to do mini ethnographies, and one of the students raised their hand and they said, okay, all of this is fine and kind of fun, but how do we know that these aren't just stories? Like, how does this not? And I was sort of a rare moment of getting upset at my fellow medical students. And it was during the Second Iraq War. And there had just been like a huge public health crisis because a water treatment plant had been destroyed. And there were 5 million children who had no access to clean water. And the diarrheal disease burden was huge and tons of people were dying. And I said, like, that entire event is because of a story. It's a story that brought the United States to go to war with Iraq and treat a certain, like stories are the thing. They are the thing that is making all of the public health the way it is. And you can just throw up your hands and say, we're just not going to engage in that and continue to be surprised when there are unintended consequences and people don't behave the way that we think they should. Or you can roll up your sleeves, get involved, and start incorporating the social world, including the stories that circulate in it, into how you think about the problems that you're dealing with.
That is fantastic. I think that's a great place for us to wrap up. Unless we have a quick question or any of the audience members, there is a raised hand, okay. I'm not sure I can see that, so is there anyone on the panel was wanting, sorry, was that Mara, did you want to finish up?
No, not at all. It was a mistake. No, I was trying to find out the chat.
Got it. Well, thank you all so much. And I know Amy was going to circle back with some final words from the center. Thank you all so much for your time today. I learned a ton, and you'll be happy. I'm a little less scared. I think I can do it. I can pull ethnography into my research going forward. So thank you 1,000 times over. Amy?
Thank you, Amy. I just want to say thank you, Cheryl, so much for your fabulous hosting and taking us through these.
You all made it
Likewise,
easy.
thank you.
Absolutely.
Thanks to everyone for a great conversation, a thought-provoking conversation, and a really, really open conversation. I mean, to challenge some of the conventional wisdom out there and really, really highlight how we can bring different methodological perspectives into our work and make it better. To all of you on the call today, we really appreciate your ongoing engagement with the center. I wanted to just share a couple quick reminders about tapping into our resources, tapping into our community. There is still time to learn about and apply for our Global Vaccine Equity Ideas Lab. That application deadline has been extended to December 17th. So take a break from grading papers or whatever else you're doing, and please jump on the website and check that out. We are also accepting faculty proposals to host our next cohort of Impact Scholars. This is the center's unique take on a postdoc program. So we are looking at those applications through December 15th, and we're planning out for our cohort that will join us in the fall of 2022. And finally, please explore the options for becoming a member of the Center for Global Health Equity. And we have made a lot of progress in terms of putting the member expertise and profiles out on our website. It's a wonderful way to find colleagues across the university and across our global partners and our collaborators to look for similar areas or complementary areas of expertise or geographic locations where people are working within. On any of these items, don't hesitate to reach out to us with any questions or for additional information. And that is a wrap, I believe. And on behalf of the center, I wish you all a wonderful winter break. Thanks again. Cheers.